Okie dokie. Well, now we can get started. Good evening, everyone, and welcome. Thanks for joining. My name's Annie Fleming, and I am pleased to be your host today for the APTA Oncology section webinar. Before we dive in, I did want to take a moment to recognize that June is Cancer Rehab Month, which is very exciting. This is the second year that we have established June as Cancer Rehab Month. So June is a time to raise awareness about the critical role rehab plays in the lives of those affected by cancer. We're very proud to be offering this webinar series as a part of that recognition, and we are grateful to each of you for joining us today. So today's webinar is the first in our series titled Optimizing Bone and Musculoskeletal Health in Oncology, an interdisciplinary webinar series. And we are kicking things off with a foundational and essential topic, bone health basics. So before I hand things over, I do have a few quick announcements. So coming up next in this series, on June 29th, we will have a webinar entitled Nutrition and PT Strategies for Bone Health in Oncology Survivors. That will be presented by Gretchen Grunder, who is an oncology specialized nutritionist, and Ashley Kenzie, who is a PT in oncology at Duke. That will be a perfect follow-up to today's session, so we do hope to see you there. It will be at this same link. On June 30th, so the following day, APTA Oncology will host How We Cancer Rehab, Pathways to Engagement with APTA Oncology. This will be a wonderful opportunity to connect with the broader oncology rehab community and explore ways that you can get more involved. Also regarding recording, today's webinar and all upcoming sessions in this series will be recorded and posted on the APTA Oncology YouTube channel. So please share with your colleagues who couldn't join us live today and check out the YouTube channel if you can't make it to an upcoming webinar. Lastly, don't forget to visit the APTA Oncology webpage to explore our library of virtual courses. Whether you're just beginning your journey in oncology rehab or looking to deepen your expertise, there is something there for everyone. So please head to the APTA Oncology section website to browse what's available and continue building your knowledge beyond today's webinar. All righty. Well, now it is my distinct pleasure to introduce our speaker, Dr. Jocelyn Wittstein. Dr. Wittstein is an associate professor in orthopedic surgery at Duke University School of Medicine and a sports medicine orthopedic surgeon who is double board certified by the American Board of Orthopedic Surgery in both orthopedic surgery and orthopedic sports medicine. Dr. Wittstein completed her residency in orthopedic surgery at Duke University Hospital, followed by a fellowship in orthopedic sports medicine, also at Duke. Her clinical work is complemented by a strong commitment to research and education, with scholarly interests spanning musculoskeletal injury prevention, rehabilitation, optimization of patient outcomes after orthopedic procedures, and the intersection of women's health and musculoskeletal health. She is a nationally recognized expert in sports medicine and women's musculoskeletal health, and her work at Duke focuses on optimizing musculoskeletal health for women, including research on injury prevention, post-traumatic arthritis, and bone and joint health across the lifespan. Dr. Wittstein has recently been invited to join the Scientific and Medical Advisory Council of the Bone Health and Osteoporosis Foundation, which is a national organization dedicated to improving bone health and reducing osteoporosis-related fractures. She also joined the Millikan Institute Women's Health Network in 2025, which was chaired by Dr. Jill Biden. Dr. Wittstein is the co-author of the Complete Bone and Joint Health Plan and co-author of a foundational paper on the musculoskeletal syndrome of menopause that has been cited more than 117 times. Beyond her research and clinical work, she has become a trusted educator for millions with over 136,000 followers on Instagram and recurring features in outlets including Oprah Daily, CNN, The Washington Post, Self Magazine, National Geographic, Wall Street Journal, and Elle Magazine. You can follow her on Instagram at Jocelyn_Wittstein_MD for more ongoing education on bone and joint health. So, quite the introduction. With all of that, we could not think of a better person to open this series. So we are grateful today to have Dr. Wittstein with us. Please join me in giving a warm welcome to Dr. Wittstein.
Sorry you all had to listen to that. That was a long introduction.
It's all worth noting. It's all very important stuff.
Yeah, so my real, daytime job is, as you mentioned, I'm an orthopedic surgeon and I train medical students and residents and fellows. But I do have a very strong interest in the intersection of women's health, musculoskeletal health, but bone health in general. And our physical therapists are just like incredibly valuable. Of course, the outcomes of our patients. I've been a patient. I think the field of physical therapy is invaluable, and so I'm excited to talk to all of you with the kind of even more specialized perspective you have. And so I'm just going to share my screen here. And then give me a second to pull this up. And we'll do slideshow. Like from the start. Okay. Everything okay? You can see? Yep. Okay. Okay. So we decided we've been planning this series of webinars, hoping to touch on many of the populations that you all treat, but we thought we'd start with just some basics. And because osteoporosis does affect women in general more than it affects men. You'll see there are a lot of studies that are on women specifically, but I'm going to try to speak to both women and men throughout wherever possible. So when we're talking about osteoporosis. So these are my disclosures. Um, Kind of what we're going to talk about tonight is, bone density, when do we accrue bone? When do we lose bone? What is osteopenia? What is osteoporosis? What causes osteoporosis? We'll talk about hormones and bone health, and then how bone health can be optimized at every phase of life and when physical therapists fit into that picture in many ways. So these are just some, high level bullet points I think worth mentioning, even though there's a lot of words on this slide. So 90% of bone mineral density is attained by adolescence. So, by the time we're 19, we have 90% of our bone density. And then our bone density peaks, somewhere between the age of 25 and 30, and then has a gradual decline over time. And bone density peak, or the maximum amount of bone you accrue, can be harmed by things, for example, like nutritional deficiencies or relative energy deficiency in sport at a time when you should be accruing bone. And then specific to women, there's a big drop off in sex hormones, specifically estrogen at menopause, which leads to this more rapid decline in bone density, actually in late perimenopause, just before the actual date of menopause, such that women are disproportionately affected by this problem because men don't have that, cliff-like dropping off of their sex hormones. So about, almost a quarter of women worldwide are affected by osteoporosis, and 50% of women over 50 will sustain a fracture versus about 20% of men. And of course, the majority of hip fractures, for example, are in women, and these do carry significant mortality. Interestingly, when men have hip fractures, their mortality rates are actually higher than women, even though they're less likely to have hip fractures. So, how do we measure bone mineral density? And, this is, of course, part of the diagnosis of osteopenia and osteoporosis is a study called a DEXA scan, which measures bone mineral density at various anatomic locations, the hip, the spine, depending on the study or how it's ordered. It may also include the distal radius. And this compares an individual's bone density to standardized results from healthy 30-year-old individuals. And basically, this generates something called a T-score. And anything that is, better than -1 is considered normal. But once you fall between -1 and -2.5 standard deviations below that mean, you have osteopenia. And lower than -2.5 is defined as osteoporosis. And when you obtain a DEXA, you can generate something called a FRAX score, which I'll talk about in a minute, which sort of gives you a risk assessment for future fracture. And then also overlaid on the DEXA scan can be something called the trabecular bone score, which more indicates the microarchitecture of bone. And this can help differentiate a truly high-risk person for fracture, even if they have osteopenia, not osteoporosis, or people who have secondary causes of osteoporosis. For example, people who have diabetes, who their bone density might not be as low, but their fracture risk may be higher just because of the way the disease affects their bone quality. And then these measures that can be generated from the DEXA can be input into something called the FRAX Plus risk assessment tool, which also takes into account various fracture risks like recent falls, rheumatoid arthritis, family history, recent fractures, all these kind of things, and it generates a risk predictor, a 10-year risk predictor for fracture. So if there's greater than 20% risk of a major fracture or greater than 3% risk of a hip fracture in the next 10 years, this is frequently an indication for osteoporosis medications. So what are the risk factors for osteoporosis? There are some that are just unfortunately not modifiable, like age, becomes a factor, especially for men over the age of 70. Women become more at risk at the menopause transition, which is on average age 52. Women are more commonly affected by men. Family history is a risk. Caucasian and Asian people have a higher risk of osteoporosis over the course of their lifetime. And then there are modifiable risk factors like dietary factors like calcium intake, vitamin D, other micronutrients, sedentary lifestyle or not, smoking exposure. Of course, nicotine is not good for bone. Excessive alcohol consumption. There are certain medications that may or may not be modifiable depending on what conditions you have. Corticosteroids, aromatase inhibitors that's not really much of a choice. It's essentially a cancer treatment. Proton pump inhibitors are medications that can inhibit calcium absorption. And then there's some medical conditions that are associated, like rheumatoid arthritis, hyperthyroidism, disordered eating that can contribute to bone loss, especially in the setting of relative energy deficiency syndrome. And then, other risk factors that we need to like take into account when caring for patients are early menopause. This can just be people just have early menopause. They go through menopause, earlier than the age of 45. Surgical menopause, people have had their ovaries removed, low testosterone levels in men, history of fractures. All these things kind of come into the picture. So what about the different stages of life? So we mentioned, there's the prepubertal phase where you might be impacted by things like nutrition or other conditions you might have, like if you have, absorption disorders or things like that. Um, but you have this sort of for in women post-menarchal kind of teens up to age 30, where you're like really obtaining most of that bone density by age 19 and then accruing till age 30. And then from the, kind of early 30s to perimenopause, there's a slow decline in general, but there's an accelerated decline that happens in late perimenopause. And then that persists into postmenopause, but not quite as a steep of a rate as in that transition. For men, similarly, they're going to accrue most of their bone density in the teenage years, a gradual decline, but not, they don't experience that steep decline at age 50, 51, 52. There's a more gradual loss over the age of 70, where then rates of bone loss do kind of become similar to women in that age group. So in teenagers, it's extremely important because they're accruing bone mass to participate in weight-bearing sport activities. And those that have impact are actually the most impactful, no pun intended, in terms of accruing bone density. So things like soccer, gymnastics, for example, these are athletes that have high bone mineral density, accruing it over those years, versus swimmers and cyclists tend to have a lower peak bone mass during that accrual time. Rowing is not really a high impact sport, but it can accrue bone density in the lumbar spine, particularly the sort of central spine or skeleton tends to accrue bone as long as people are adequately fueled. And then this is just sort of a study looking at a pediatric resistance training intervention where for 2 years, kids in middle school, girls were trained on resistance training. And then the benefits of that intervention persisted for a few years after the study was completed. And gymnasts, of course, have really good bone density because they're weight bearing and impacting both their upper and lower extremities. And that does persist into adulthood because they get a higher peak bone mass because of it. So what could go wrong? Let's say you get to, the end of your teenage years or you're, athletic in your 20s. You're accruing bone perhaps from these high impact sports. Well, even if you're participating in sports that do help you accrue bone, there is a condition called relative energy deficiency in sport, in which chronic energy deficiency basically leads to a hypothalamic suppression. And in female athletes, a low estrogen state, but this can also be a low sex hormone state, lower testosterone levels, for instance, in male athletes, and that can affect their risk for things like stress fracture and bone mass accrual as well. But it does tend to be more common in female athletes, although the condition is now called relative energy deficiency in sport because it can affect both male and female athletes. We don't really refer to it anymore as the female athlete triad. This is a picture from the International Olympic Committee consensus statement on this, looking at all the different aspects of health that are impacted by this low energy state. But of course, what we're kind of focusing on today is this suppression of sex hormones and the impaired bone health aspects of it. So in female athletes, this is often treated with first trying to correct the energy imbalance, the nutritional status, training adjustments, recovering from bone stress reactions or fractures before reinitiating training. And in cases that are just really recalcitrant to reestablishing normal hormone levels, this can actually be treated with transdermal estrogen, and sleep hygiene is also important. So, speaking of estrogen, as I mentioned, obviously women are more prone to all of these bone-related conditions because of these effects. As women go through late perimenopause and menopause, all of these parts of the musculoskeletal system are affected: cartilage, bone, synovium, muscle, possibly even ligaments or capsules of joints, by estrogen receptors. And dropping estrogen levels do then result in that more rapid loss of bone density. Questionable, mixed, I would say mixed studies in terms of the data on whether or not the declining levels of estrogen directly impact the ability to hypertrophy or maintain muscle mass. There is some mixed data out there on that, but estrogen does have a direct effect on, at least in animal studies, on satellite cells, which allow muscle to hypertrophy. But there are mixed results when looking at hormone therapy and muscle mass in menopausal women. There's something called menopause arthritis, where essentially joints become more inflamed and there's increased risk of frozen shoulder, all affecting, the ability to participate in resistance training in some cases. Menopause, of course, is a date. It is 1 year after the last menstrual cycle. And in the United States, the average is age 52. And the long-term consequences of this hormone transition, a lot of them tend to be musculoskeletal. And one of the topics, of course, we're talking about today is long-term effects on bone health, the increased risk of osteoporosis and hip fractures. We did publish this paper called The Musculoskeletal Syndrome of Menopause, which does kind of summarize some of the anti-inflammatory effects that estrogen has, and then how that shows up when that inflammation suppressing effect is removed, with particular focus on bone health and joint health and risk of frozen shoulder. Now, we know lean muscle mass is essential for maintaining bone mineral density. We know that resistance training absolutely helps to maintain the bone mineral density, but there are also studies showing that actual body composition and the amount of lean muscle mass we have does correlate with bone loss in early postmenopausal women. Now, what's interesting is I mentioned, men don't have this cliff-like change in their in their sex hormones, and so we see this dramatic change in women in midlife. Men don't generally experience that change unless they have like an orchiectomy or they're on androgen deprivation therapy, which we're going to talk about in subsequent webinars when we're talking about, for example, patients with prostate cancer and the effects of androgen deprivation therapy. This is what women's bone loss looks like in midlife. That vertical line represents the actual last menstrual cycle. And so 1 year before the last menstrual cycle, there is this more rapid decline in bone density in women. And so the actual decline starts really 2 years before menopause, which is often overlooked. Most people think the bone density decline starts after menopause. It actually starts 2 years prior. And this is data from the study of women across the nation, which is a very large prospective study looking at women at that perimenopause transition. And estrogen has this effect of inhibiting osteoclasts, the cells that break down bone. And so therefore suppressing bone breakdown in favor of bone formation, and therefore there's less net bone loss. But this happens through multiple mechanisms. And some of these are similarly affected by actually osteoporosis medications. Now, the Women's Health Initiative showed us that hormone replacement therapy in women can dramatically reduce hip fracture risk, also vertebral body fracture risk, and that osteoporosis prevention is an FDA-approved indication for hormone therapy. Reducing joint pain is not, although that seems to be a welcome side effect for many women. And this is a similar, result seen in a meta-analysis of all the randomized controlled trials looking at the bone health protection, fracture risk reduction effects of hormone replacement therapy in women. And this is a study that was recently published in The Lancet showing that there's a time effect. So the longer women are on hormone replacement therapy, or now called menopausal hormone therapy that contains systemic estrogen, the greater the risk reduction of fractures. And then when this is stopped, that benefit does tend to recede, although there is some retained benefit in those women who are on this for a longer period of time, like 10 years, for example. Now, in men, you would say, well, if men have low testosterone, you would expect testosterone supplementation to improve bone density and reduce fracture risk, just like estrogen has in women. But interestingly, this is a trial called the Testosterone Treatment and Fracture in Men with Hypogonadism trial. They found that, well, replacing testosterone in states of low testosterone in men did improve bone mineral density. It didn't reduce fracture risk. So there's not that exact same interplay like we see with hormone replacement in men and women. And the treatment of choice for osteoporosis or osteopenia in men that are high risk for fracture would be, some of these osteoporosis medications. Of course, women also need those as well many times, but estrogen does seem to have a fracture preventative effect, certainly in the state of osteopenia. So, what are the interventions for adults? Let's say, we are, we're at adulthood, we've reached our peak bone mass, and maybe we're 50. What do we do? We're in this potential state of decline. There are many lifestyle interventions, and some of these will be discussed in the next session with particular attention to oncology patients. But there are dietary aspects. You can avoid smoking, you can minimize alcohol. You can make sure you're maintaining proper vitamin D levels. There's fall prevention and balance work, a little bit of agility so you don't fall, maintaining our mobility. But the key pieces of optimizing bone density, not just the fall prevention part, but optimizing bone density is really resistance training and then providing some load on the bone, ideally with impact if that is appropriate, or something that you can tolerate based on your history. So we know that strength training, resistance training primarily increases bone density in the lumbar spine, and impact training, such as jumping, heel drops, things like that, primarily affects the femoral neck or the hip region. There is some reasonable data, I think, on hydrolyzed type 1 collagen for supporting bone density, and also pairing resistance training with creatine monohydrate. And then, of course, adequate dietary macro and micronutrients. I like the schematic of this review here, which is a systematic review of 50 randomized controlled trials. And basically, what the article shares is that effective programs for improving bone density include resistance training and some impact, and then ideally balanced training to reduce falls, which therefore also reduce fractures. The classic trial that is often quoted for resistance training is called the Liftmore trial, which is a more intense program. This is considered a high intensity strength training program, where women with osteopenia and osteoporosis were progressed over a few months to then participate in the high intensity strength training program for the last 5 months of the study. So it was an 8-month study. And they participated in deadlifting, overhead press, back squatting, and they did some jumping chin ups to get some impact. This was done a couple of days a week, and at the end of the study, this is a randomized controlled trial. The intervention group gained 3% bone density in their lumbar spine, versus the control group lost 1%. There was a smaller gain in the hip region, also with a loss in the control group. So this was thought to be an effective tool, and you'll often see this cluster of exercises used. And again, you see it includes a little impact, and then kind of loading from what I call from the top down. So you're loading the skeleton, you're carrying the load through this resistance training. So impact exercises are not always just jumping pull-ups. You may have someone who's able to do more, like, for instance, a little 8-inch drop jump off a step with a rebound exceeds the threshold for creating an osteogenic response called mechanotransduction, where impact sends a mechanical signal to osteocytes, which then convert that into a biochemical signal and essentially are stimulating bone formation at the site that is loaded. And so this is particularly effective in the hip region. This doesn't have to be a ton of jumping. There are studies that show, 30 jumps a few days a week is helpful. This is one study that showed some small improvement doing this for 6 months. And then, there are other studies showing this isn't as effective in postmenopausal women, more effective in premenopausal women, showing larger effect. There was a study called the Jump 10-20 study where they had, showed even that women just jumping 10 times 10 jumps twice a day was effective, or 20 jumps twice a day was also effective. So it doesn't require like a lot of impact, but impact training is helpful for the hip region. Now, this is my favorite acronym. As many of you may know, weight bear is tolerated because not everybody can jump, not everyone can lift heavy. We have to meet people where they're at. And of note, we don't have to do all of that really hard impact, like jumping off the step with a rebound. There is benefit to something just called a heel drop, also moderate intensity stomping. You can, I just put this in here for fun for you. You can do this. So this song has, you could do multiple rounds of stomping and heel drops with some squats in between. But for fun, we should note that you do need to rest a little bit in between jumps. So if you don't rest at all, your bone equilibrates to all the impact. And just there's a diminished response to the impact training. So you actually want to rest some in between. It takes about 14 or 15 seconds for osteocytes to reset for their sensitivity to mechanotransduction. So you don't just want to jump, 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 jump forever. It's good to do some jumps and take a break. So what about walking and bone health? Speaking of weight bearing is tolerated, there are people who cannot do jumping. They can't, maybe they've got a lot of arthritis limiting some of the other things they can do, but maybe they can still walk. You'll often hear people say like walking is not enough for bone density, but I do want to recognize that this is better than nothing. It's better than being sedentary. I think probably oftentimes with oncology patients, they're recovering from treatments. They might not have the energy to do much more than walk. And we know that walking slows the loss of bone density. Doesn't necessarily increase bone density, but it slows the loss of bone density, and it reduces fall risk. It helps with maintaining gait speed, and it reduces hip fracture risk. And you may say, well, how much do people need to walk for this to be effective? The Nurses Health Study showed us that 35 minutes per day versus not regular walking, like reduced hip fracture risk by like 41%. This study looking at this was in JAMA, I think, looking at how many steps per day were effective for reducing things like fall risk, and it was 7,000 steps a day. So this may be something that's more attainable for some of our patients. And then more walking is related to the more walking exposure there is, people tend to have better bone density as compared to people who walk less, but it's not effectively going to increase bone density, but it is still a supportive thing that many people can do and it's accessible. So where do you start if your patient already has osteoporosis? They're not going to like jump right into the lift more trial. They're not going to be doing heavy deadlifting, for example, right away, perhaps. Or perhaps you have a patient who's recovering from, they recently recovered from an osteoporotic fracture. This is where programs like BoneFit come in, and many of you may be BoneFit certified, where there is a focus on core strengthening, avoiding high-risk positions like loading of the lumbar spine and flexion, graduated load, like small impacts, light resistance, to start to load the skeleton, and then, possibly progress, depending on the individual. And I think we'll hear more about that in our next session in terms of how you go from someone who is needing to be at that entry level of bone fit, maybe someone who has osteoporosis or recent injury who's not done any physical fitness in a long time, versus there are people who have just been diagnosed with osteoporosis who are quite fit and have been doing lifting and impact, and they're, not needing to maybe start right here. So there is a wide variation of presentations. I mentioned that there is some reasonable data, I think, behind using hydrolyzed type 1 collagen in terms of having a positive effect on bone density. This is an example of a study. It was an industry-funded study, but I do think it was done pretty well, and they did a short-term and a longer-term follow-up and showed some benefit. And then creatine monohydrate, I mentioned earlier, does not directly improve bone density, but does have a sort of indirect effect. There are studies showing increased lean muscle mass when combined with strength training that could then have a secondary benefit in terms of effect on bone mineral density. And then, of course, diet and nutrition. So some of the important micronutrients are calcium, which you can get through dairy, cruciferous vegetables, kale, bok choy. Spinach is not an excellent source of calcium, it turns out, just because of its bioavailability. Vitamin D, can be gotten through things like eggs, fatty fish like salmon, mushrooms, or supplement can be taken. Anyone who does not have a vitamin D deficiency should not exceed 4,000 international units daily of vitamin D. But depending on what someone's vitamin D level is, they might need to take a supplement, or they could maintain on a supplement. There is some evidence that at the level of 2,000 international units per day or higher, there can be some benefits in terms of reducing joint pain. And as you know, as physical therapists, there are many times that you're trying to thread the needle between joint pain and losing muscle mass, maintaining bone density, and sometimes there is some working around joint pain. Magnesium is a key micronutrient. It is a necessary cofactor for vitamin D. It also interacts with parathyroid hormone and is part of the crystalline structure of bone. So this can be gotten through leafy greens, seeds, and whole grains. Um, and some people struggle to get that in their diet and might utilize the supplement. Vitamin K2 is necessary for the activation of osteocalcin, which helps with the mineralization of bone. And so this can essentially help direct calcium to bones. This is also a little bit tricky to get in the diet. This can be gotten primarily through fermented foods. There's something called natto that's very high in vitamin K2, but most people don't eat. There's a little bit in organ meats, some in eggs. But this is actually, I think, a reasonable supplement for a lot of people to consider taking just because it is a little harder to get from their diet. There is, and soft cheeses actually as well, or include some K2. Um, and then dietary fiber, very important for gut health, but the generation of something called short chain fatty acids, which do have this effect on bone metabolism by and a pathway through nuclear factor kappa beta, rank ligand suppression, and then actually suppression of bone breakdown. So that actually is significant for many reasons, but for health benefits, but particularly for protection of bone. And then there's data on something, like basically anti-inflammatory diets as measured by something called the Dietary Inflammatory Index. You'll see mixed definitions of this, but essentially avoiding too much saturated fats, fatty red meats, including whole grains, lean proteins, omega-3 fatty acids, colorful fruits, vegetables, and these phytochemicals that are helpful, including antioxidants like anthocyanins. Um, there's the 30 grams of fiber per day. And specifically, this has been studied in women, both premenopausal and postmenopausal, in prospective studies, and shown to be associated, like the better the dietary or the lower the dietary inflammatory index, the lower the future fracture risk. So other conditions or considerations when treating, like, let's say, hip fractures, which is one of the most common fragility fractures that we see or you may see, physical therapy can be an incredibly valuable tool when working with these patients who then have kinesiophobia, fear of movement. They're so afraid of falling. I'm helping them to restore balance and mobility as much as possible. Just sidebar, and we'll probably mention this again in one of the subsequent webinars where we're talking about patients with people who can't use menopausal hormone therapy, maybe they have a contraindication. There is a different delivery method for local vaginal estrogen, which can help reduce recurrent urinary tract infections. And you may recognize a lot of patients who have hip fractures often have recurrent UTIs, and UTIs are a source of confusion, imbalance, falls, and also one of the most common complications of a hip fracture and one of the causes of death, urosepsis. So vaginal estrogen is a tool that a medication that can be used in that population to help at least diminish that risk factor. Oncology patients are at increased risk for osteoporosis. We have breast cancer patients who are on aromatase inhibitors, which essentially inhibit the conversion of testosterone to estrogen and therefore are having a negative effect on bone density. Some breast cancer patients are treated with tamoxifen, which interestingly is essentially like a selective estrogen receptor modulator. In a premenopausal woman, it would be diminishing bone density, but in a postmenopausal woman, it can actually support bone mineral density. There can be chemotherapy associated early menopause, surgical menopause with oophorectomy, prostate cancer patients on androgen deprivation therapy are going to be at increased risk for osteoporosis. And then just people undergoing treatments where they have perhaps low energy, maybe they're not as well nourished. They're going to be at risk for sarcopenia, lower activity, lesser weight bearing status, which again is going to make them more at risk for osteoporosis. So, in summary, bone density peaks early. therapeutic exercise, including resistance training and impact exercises, improve bone mineral density and slow bone loss. But we have to kind of see and meet people where they're at. We have to recognize there are some things that will maybe not improve bone mineral density, but still slow bone loss. And just because people can't do heavy resistance training doesn't mean that there isn't still benefit to lighter or moderate resistance training. We need to recognize the risk factors both early and late in our patients' lives for making them, at risk for osteoporosis. And then we have the opportunity to educate about healthy lifestyle choices at all ages. And then it's really important to collaborate with the healthcare team, especially for complex patients. And with you all being oncology PTs, I'm sure you're quite accustomed to, needing to do that. So that is my last slide, which means we have time for questions. And I hope this was helpful just as a general introduction to this series, which as I mentioned, we're going to kind of hopefully tap into a lot of the different patient populations that you guys care for. So I'm going to stop sharing my screen and then we can do questions.
Thank you, Dr. Wittstein.
There's something in the chat here. Let's see.
Yeah, that was probably me
Oh, yeah.
from the beginning.
That's you. Yeah.
But yeah, please feel free to unmute if you have a question or if you feel more comfortable putting it in the chat. I'd be happy to
Mhm.
read it aloud.
Yeah, a lot of times people don't feel comfortable on Zoom, but I imagine a lot of your group have some of the bone fit training as well. Or
I don't know how common that is in like oncology specific PT, but a lot of folks do kind of work in like orthopedic and then like see an oncology population as part of that. So, I don't know if anyone has the bone fit certification. I do not.
Yeah.
I think something that like really struck me because, going through all of that, a lot of the things that are like used to manage bone density are things that like our patients are not going to be able to do, like you said, like hormone therapy or hormone
Yeah.
replacement therapy. So, I appreciate that like sometimes it doesn't have to be like jumping and like these really like
Hmm.
high intensity things to still get benefit. So I think that's something that I'll kind of take
Yeah. I
going
mean,
forward.
that's the tricky um that is the tricky part for like so many oncology patients. Yeah, there's not really necessarily well, there is a choice, but I mean, they don't really have much of a choice in terms of um yeah, some of the medication regimens they need to be on. Um, I think that nuance, and we'll talk about that later in a subsequent meeting, but there are like some nuances like aromatase inhibitors versus
Mm.
tamoxifen and at what age you are
Hmm.
and things like that. And then, you know, yes, sometimes there are some things that are not under under our control. But I think uh there is so much benefit to like the exercise interventions if people can do them. And hopefully many people who are going through these treatments have access to some good nutritional advice. Um, but I think especially for people who are, like I said, going through treatments where they have like poor energy, availability, or they're just not feeling well. Yeah, some of these like really high intensity things are maybe not going to be
Hmm.
accessible to them. But it's still better. Something is better than nothing, and like helping people maintain muscle mass, helping them not atrophy,
Hmm.
um, just trying to keep people mobile, even if it's just, like one extreme is having no weight on your legs, being on crutches or being in microgravity, you
Hmm.
will lose bone density and muscle even faster than if you're just standing or walking. So I think it's just important to not like diminish the things that sometimes are said to not be enough because just because something isn't improving your bone density doesn't mean it's not slowing the loss of it, basically.
Hmm. Yeah, and I feel like with, you talked about a little bit aromatase inhibitors and how they affect, bone mineral density. And the thing that we most commonly hear with aromatase inhibitors, the side effect is joint pain. So
And
people
joint
don't want to
pain,
move. Yeah.
definitely. Yeah.
I think kind of using some of this to educate patients. And then, like I said, or you said, was it 10 jumps 2 times a day can be effective? Like that's
Yeah.
a pretty
Not to do
low.
too much, but yeah,
Yeah.
it is so true. Patients on aromatase inhibitors do have a lot of joint pain.
Mm,
Um, well, it has a name, Ames,
mm.
aromatase inhibitor. Forget what the MS stands for now, Ames, but yeah, so that is definitely another limitation for people. So yeah, like just maybe not overwhelming people with too much, giving them, just a smaller amount to do, things that have some effectiveness, even if not in huge volume, can be helpful, I think. So
Yeah, definitely.
anyway, it's a quiet group here. Um, well, if you think of any more questions and you want to send them to me, I'm happy to answer them for you or try to. And then, of course, I'm not an expert in everything, so we're pulling in some experts in other areas: breast cancer, prostate cancer, sarcoma, all these things that will be the main expert. I'm just going to facilitate most of the rest of this series. So,
I wanted to jump in with a question. So I think first off, wonderful presentation. Lots of really great information. One of the things that I struggle with, especially after leaving work at a large cancer institute, is how do we advocate to help our patients that are needing some more of these resources and needing some more of the support? What can we do as therapists to help with that?
yeah, I mean, I don't know how coordinated, hopefully their care is somewhat coordinated, but yeah, just I mean asking them, have you seen a nutritionist? Um did, did they have a DEXA scan before aromatase inhibitors were initiated? Um for instance, if someone is on some intervention that causes joint pain, sort of just recognizing like this is going to cause joint pain and like I think it's sort of just being on board with like recognizing what symptoms they're going to be dealing with can be helpful. um I don't know, that's a really broad question, but I think in general, yeah, if they it would just asking them if they have gotten any counseling related to their diet and nutrition. And obviously if they're seeing you, they're getting some of that physical therapy piece, which is good. Um, if they don't have any access to equipment at home, maybe like thinking through some sustainable exercises or interventions they can do when they're not with you. I think that's often the case with physical therapists, and I think you all work wonders with people who have very little resources all the time, uh, with body weight and resistance bands and some good instructions. But I don't know if I have the answer to that entirely.
Yeah. One thing with nutrition too, because I find, and I think Gretchen will talk about this a little bit more next time I spoke to her about it too. Nutrition consultation for the oncology population is so needed and unfortunately difficult to access.
Hmm.
So I'm pretty sure Blood Cancer United, which was formerly the Leukemia and Lymphoma Society, does do a free consultation for anyone with a cancer diagnosis.
Oh,
Um,
that's nice.
so if anyone out there is looking for a resource for that, I do think that that's available. And like I think I'm pretty sure it's virtual. Um, so that's always a good resource, at least for nutrition. And I think you highlighted the important role nutrition plays in, bone mineral density, amongst other things, especially in this population. So
Yeah, and to be clear, the reason we did this talk first is because it's sort of like uh, a baseline sort of jumping off point, and then from this we have to think about each of these populations differently. So obviously we'll plan on talking more about joint pain and frozen shoulder and lymphedema and aromatase inhibitors, as an example, that breast cancer patients might be dealing with and facing as compared to this is a general bone health basics talk, although we did kind of want to highlight some of those populations that are affected. So,
We did have a question in the chat from Serena. She asked, is there a difference with age-related osteoporosis versus cancer treatment-induced osteoporosis?
Well, it's a lot of times there's a chemotherapy basically associated early menopause or um, early, effect on the gonads. And so um, that can be like, for example, if a woman is treated with chemotherapy and then they essentially go into early menopause, it's almost like a surgical, not, it's not surgical menopause because they didn't have their ovaries removed, but it is an early menopausal state. And so it's like that is a big risk factor because then there's going to be you're basically just shifting that clock forward um, for for a woman to be put into a state where they don't have estrogen or a man to be put into a state where they don't have testosterone. You're going to shift that decline that a woman would otherwise experience at, age 50 or a man at age 70. It's going to be shifted upwards, which means you're going to have more years of decline in bone density and more risk for fractures in the future. So, um, if that
So it
makes
sounds like it shifts.
shifts
We're just
things.
talking because it starts earlier, it shifts, but like there's no true like biological difference or like what's actually happening is not different based off of if it's chemo induced versus
Yeah, I mean that is my understanding of that. We should raise this question again in some of our later sessions and see what people say. But yeah, it's I mean the same reason that, many people who go through cancer treatment are then infertile. They can't have children.
Mhm. Yeah.
Or they can have children, but not through they have to use other means. Yeah.
Yeah.
So, mhm. Oh, Bone Fit. Yeah. So Bone Fit, someone said, can you talk more about Bone Fit? It's a certification that was originated through the Osteoporosis Foundation of Canada, and then it was kind of adopted through the Bone Health and Osteoporosis Foundation in the United States. And they offer certifications through to physical therapists, but also to help to certified like fitness professionals as well. Um, and it's basically a starting point for, how do you start to train someone who is presenting where they already have osteoporosis, and you need to do things like improve their core strength, fix their posture, not, put them in a flex spine position and load them. These are for people who are already like fairly into physical fitness or quite active. Some of these things would be pretty elementary and not very challenging, but there are people, as you know, who are lacking a lot of the basic strength and postural control and things like that. So it's a much more like early introduction into, load bearing activities, core strength, um, protection, avoidance of at-risk positions. And I haven't actually done the curriculum myself, but it is, I know it's a certification available. So they have like they offer the course multiple times a year. I think it's just a 2-day thing. But I know people, and I think we're going to talk about that actually at the next meeting. I think we'll learn more about it. But I think it is a helpful framework for people if you're starting to work with someone that already has significant osteoporosis, or for example, is maybe recovering from, a recent bone health related osteoporosis related fracture. The opposite end of the spectrum would be like the Onero program, which is like a high intensity resistance program that is modeled off of the Lift More protocol. That's not where someone like that is going to start. And there are now like more and more home apps available. There's something called Osteo Gains, which is a progressive impact app that you can do at home that starts with like lower impact and gradually builds up over the course of a year to like higher impact and jumping, for example. But that's just not going to be appropriate for everyone. So, but yeah, we should talk more about that in our next session.
Yeah. Well, if anyone else has any questions, speak now or forever hold your peace.
I have a question. Um, I'm sorry, I didn't join until just like 20 minutes ago because I was otherwise occupied. So I will go back and listen or watch this
Oh, that's okay.
recording, hopefully, once it's posted. But my question is, you may have already covered this. At what point do you recommend bringing up to the patient about preventative exercises because perhaps they're on an aromatase inhibitor or they already have a pre-existing diagnosis of osteoporosis going into treatments because we go over so many things in that first couple of visits um, about lymphedema prevention, range of motion, preparation for surgery and whatnot. I'm just wondering at what point is it a good segue into exercises to improve or reduce the acceleration of bone loss?
I mean, hopefully someone who's prescribed the medication has told them about this. Hopefully they've ordered a DEXA scan, prior to initiating an aromatase inhibitor. Hopefully there's been some background about it. And I don't know if you're seeing them if they're already on the aromatase inhibitor and already experiencing the joint pain, or it's like going to be coming depending on when you're seeing them. But um, yeah, I mean, I know what you mean about being overwhelming to a patient in a visit. It's like when I'm counseling someone for surgery and there's only so much you can tell them and
Mm-hmm.
let them absorb at one time. But I I mean, I think it is important for them to know that early on. Hopefully, you're not the first person telling them that. But also that, with aromatase inhibitors, there is like one of the most common complaints, or not complaints, side effects, it's not as joint pain. And they may need to work with you or someone to find ways that they can participate in, if they can participate in resistance training, for example. And I think that's probably individualized, but um, yeah, I think it's good to talk about that early, and just that you're going to try to thread the needle between joint pain and load bearing
Mm-hmm.
exercise and do what you can do together, but hopefully someone has introduced that concept to them besides you. I don't know how often you find yourself introducing concepts like that.
Too often, too
I
often.
know.
Yeah.
Uh,
Okay.
yeah. Sometimes I find myself explaining that to people, unfortunately, but yeah. Or maybe it was explained, but it was more than could be absorbed in the,
Exactly.
and so
Yeah.
I think it does help to hear things from multiple trusted sources or parts of a care team. Because sometimes I find myself explaining that also.
I find like commonly patients come in and they're like, yeah, I went to get this scan and they like don't know what it was. And then
Oh, why they went, like why they
yeah,
had a DEXA?
yeah. If they're getting prescribed like an aromatase inhibitor and then you can
Hmm.
kind of like onion layer, in
Yeah, so
what that.
someone sent them for the study because it was needed, but maybe
Mhm.
they didn't understand what it was in preparation for. And then, of course, a lot of these patients are also on bisphosphonates or
Mhm.
or
Yeah.
osteoporosis medication at the same time. So, yeah, it probably helps to have some people saying the same thing consistently.
Mhm.
And again, we'll talk about that in another session. So,
We're layering. We're
yeah,
we're
we're
peeling the
layering.
onion
Yeah,
too.
we're just laying some groundwork here
Yeah.
for the like the sort of the less affected state. Yeah. So layers.
Well, thank you everyone for joining. Like I said, this talk and then all subsequent talks will be on the YouTube channel, which I'll have posted on the APTA Oncology Instagram. And I'm pretty sure you can also get to it from the APTA Oncology website. So please join us for our next session on June 29th. We're doubling up in June with 2 webinars for Cancer Rehab Month. And then we'll kind of go every other month from there. As Dr. Witzine said, just kind of getting a little bit more specific, focusing on different patient populations and having broader panel discussions and more experts come join us. So if you have any comments, I'll put my email uh, in the chat as well. If you have any questions forgot to ask or one comes up later, I'm happy to forward them to Dr.
Yeah, and
Witz.
I can join the next session, even though I won't be the presenter on the PT, interventions and nutrition. But I'll come, I'll join, and then we can chat.
Lovely. Awesome. Well, thank you guys. Thank you, Dr. Witzstein. We enjoyed having
Okay.
you.
Okay, bye.
Bye.